On behalf of IMED Radiology, I'd like to welcome you to our presentation on shoulder pathology. Case 1, Lachlan. Lachlan is a 17-year-old student. Now, he's a lucky boy. He's been skiing over the weekend, but he's had a fall. So whilst he was skiing, he fell onto his outstretched arm, he heard a clunk and he was in instant immediate pain. And it's remained painful ever since that time, but he can move it in all directions with some discomfort. Okay, are you ready? This is where we join in. Right, question number 1, everyone. What do you think could possibly be going on? What are some of the possible causes with Lachlan? AC joint, very good. So a dislocation or a sprain, strain, yeah, something to that joint. Yep, very good. Yes, skiing experience, appreciated. Collarbone, I heard. Yep. Yes, okay, so he's fallen, he's had a fracture through his collarbone. Yep, very good. Glenoid labrum, that's a very advanced diagnosis and I appreciate hearing that. Very good. And that's a tricky one, isn't it? Because to come up with that instantly when they're sitting in your consulting room is often a hard diagnosis. Anyone else? What could he have done at the time of injury? It may not be there now. Dislocation, that's right. So has he subluxed or has he dislocated when he's fallen and maybe he's had a spontaneous reduction or something like that? Yeah. Anyone with anything else? I'm guessing possibly just even humeral pathology, so it could be a fractured neck of humerus or something like that as well. Greater trochanter. AC joint, that's right, yep, we said AC joint, exactly. So all of those important structures in terms of bony anatomy, that's right. Dr. Remington, have you got anything to add with regards to our differential there?
All of those things, I think, are a very good list of differential diagnoses. I tend to break it down into dislocations and fractures in that age group. So my differentials always are fair, and this will be a recurring theme tonight, fairly age group specific, but all of the things you mentioned on the list of differentials, and you mentioned glenohumeral joint dislocations in that age group with an outstretched hand. It could be a glenohumeral dislocation, and it still could be posterior or anterior. And you mentioned AC joint pathology, collarbone fractures, but other specific proximal humeral fractures are certainly possible, as Sharon was alluding to. And don't forget the other soft tissues. You mentioned labrum, but capsular stretch or capsular rupture. And even though he's a fairly young person, rotator cuff pathology is possible even in those young patients. So at this stage, it's still a fairly broad differential.
Thanks, Dale. Okay, question 2. So he's sitting there. We've already had our brain ticking over as what could be going on with this young chap. What specific questions should we be asking him to really be fine-tuning now our differential? Hands up. Questions for our patient Lachlan.
Painful arc.
Painful arc? Yep. So when we say that, we mean sort of pain on elevating and abducting, don't we? So we want to know where his pain is. And you were right at the start as well. Where exactly is his pain? Can he put a finger on it or can he give you a region that's sore? Yep, exactly. Any particular movements that change that pain or that bring on that pain? Yep.
I think this is a little bit difficult because we don't know how long after the injury we're seeing the patient.
Yeah.
And but the history is, even though he might even volunteer his diagnosis, he probably saw someone on the slopes and he said, I've had a dislocated shoulder or an AC joint injury or a fracture, and give you more information. The history is still really important because if it's early on after the injury, examination may be really limited. So they may have very minimal movement. They may be too sore to do specific tests like putting them through a painful arc, even though that might be appropriate. So I rely a lot on history. Even if they tell you the diagnosis, you've got to take it back a step and ask about that mechanism. He says he fell on an outstretched hand. I don't think you can accept that. You've got to ask exactly what position the arm was in. And if it was abducted and externally rotated, be suspicious of an anterior dislocation. If it was forward flexed and in an adducted position, be suspicious of it going out the back. So the history will lead you down a specific path. So don't be happy to move on too quickly to examine these patients. He may have a history of dislocations and say, this is, I've had this 10 times before, is exactly the same as the other previous occasions. Ask if it was dislocated, did it go back in on its own, or how long it was out. If it's out for a prolonged period, then worry about secondary pathologies like large Hill-Sachs lesions and even neuropraxias or neurological injuries such as an axillary nerve. Whether he had a burner or a stinger or tingling down his arm for a while afterwards, he may have a plexus injury in isolation or with one of these other diagnoses like a dislocation. Sorry. Yeah, well, I'm sure between the professor's slides and mine we'll have a photo of or an image of a Hill-Sachs, but basically that's an indentation at the back of the humeral head that happens when in an anterior dislocation, where the postero-superior aspect of the humeral head is resting against the sharp corner of the antero-inferior glenoid and leaves an indentation. Hill and Sachs were just the people the two guys who described it initially, but other names you might see as a hatchet lesion or an impaction fracture on a report describing the same pathology. So neurological, whether he had numbness, whether he or someone else noticed a deformity. So AC joint, that'll be obvious if it's a superior separation of the AC joint. Or did the shoulder itself look different afterwards? In anterior dislocations, often patients will volunteer my shoulder was sitting forward. Posterior can be more subtle in their clinical findings, but often they'll give you this information and it'll give you the diagnosis. And sometimes it's almost misleading if they tell you too much. They might sort of narrow things down too much, so keep a fairly open mind because often these patients will have dual pathologies. It's not uncommon, usually in an older patient who has a dislocation, to have a rotator cuff pathology or tear as well. So I don't know if anyone else has got anything to add, but I'm sure there'll be a lot to talk about in the imaging part of things, but history is still vital before touching the patient's arm.
In terms of the actual appearance, it strangely enough becomes relevant for radiology. I'll tell you what happened a couple of weeks ago. A sonographer asked me to look at a patient because she was having huge difficulties eliciting the normal anatomy on an ultrasound study of the shoulder. A patient that had injured their shoulder 3 weeks previously. I went in there, stood at the door and smiled because I knew the diagnosis from the edge of the room, because the shoulder, rather than having a nice rounded contour, had a sharp cut off and they actually had obviously dislocated their shoulder. So all it required wasn't for me to do the ultrasound, it was got an x-ray done which showed his chronic dislocation. And it's one of the things that is probably the hardest to teach sonographers, is to actually how to take in the clinical information around the patients when you're actually examining them.
So that was Dale's points, a lot of those points that he mentioned there. Right, question 3. This is where we've been itching to get our hands onto the patient. What specific physical examination findings would you then be looking for in Lachlan? Deformity, absolutely. So as Prof has alluded to, we want to be looking at the shape of that shoulder. We want to be seeing if it has its nice rounded contour or not. Yep, absolutely. And even the AC joint, you'll see an obvious superior deformity there. Other features on examination? Yes, numbness. So a neurological examination, as Dale mentioned, that's right. And it's very quick, isn't it, to take a history with that. You just want to say, is there anywhere that's numb or has pins and needle? Does anything into the hand or arm feel as though it's weak or not moving properly? So that's your history. And then when you get to actually examine that patient, again, you're doing a very quick sensory check, making sure everything feels normal. That's right. Yep.
For these types of people that may have had a one-off dislocation, are they likely to have a positive apprehension test or a positive sulcus sign, or is that more of a chronic?
No, that's correct. So that's part, once we're getting to that glenohumeral joint and we're assessing it, and remember we want to see how much he can move before we try and put him into that apprehension position. But you're right, we're looking for evidence that there may have been a dislocation, and so that apprehension test is looking to stress them in that sort of abduction and external rotation position to see if we might be trying to lever the humeral head anteriorly out of the joint. So he might have that acutely, but he may be too sore if it's only within that first week or so. He mightn't let you get him up into that position. And then the sulcus sign, as you know, when we pull down on the hand and we're looking for a little sulcus to appear beneath the lateral edge of the acromion, that's evidence of possibly an inferior weakness in the joint capsule there. So yes, they can have those acutely or chronically if they're a recurrent dislocator. Yeah. Remember, when we're examining, we're always going back to those first principles with any joint, aren't we? So look, feel, move. And when we're moving, we're looking for his range of motion, but then we're also doing any special provocation tests. Okay, I might hand over to Dale to see specifically when he examines these shoulders, what things he wants to pull out of his examination.
So again, I think, as Sharon said, look, feel, move and x-ray. I still think, and we'll talk about this more, but x-ray is still important. But just before laying hands, have a look at the patient, disrobe them in an appropriate fashion so you can see the full shoulder girdle and compare it to the other side. It depends a little bit on, as I mentioned before, how acute the dislocation or other injury is. But you'll get a lot of information from inspection, particularly in the acute situation with swellings, with AC joint deformity, comparing to the other side. If it's in the chronic situation, you'll see atrophy often of their deltoid or their rotator cuff muscle bellies. And you have to have a look at them from the front, the side and the back to get this information. Often they'll have, sorry, I shouldn't say often, but sometimes you'll pick up someone who's got a genetic or a dysplastic predisposition to having shoulder problems, such as dislocations, someone with ligamentous laxity or Marfan's, one of these conditions, and often they'll have the systemic features of that, like chest deformities or elongated limbs or double jointed thumbs, and they might even show you some of their tricks with double jointedness, which predisposes to shoulder dislocations. So look, and the other thing is you start moving them early in the exam and they're sore, the exam findings will stop very quickly. If you hurt them early, you've got to just sort of work up to those. So look, feel, move, and I break the movement down into active tests, passive tests, and then power, and then special tests afterwards. And the special tests are a little bit specific on what your differential list is, but if it's instability, it's apprehension tests, and Sharon mentioned them, and the anterior apprehension test is in abduction, external rotation. But you do have to be, in an acute setting you might be able to do that. They might get to here and they feel apprehensive. But if it's someone who's in between dislocations and seeing you for a chronic problem, you have to spend some time doing that because it does give you information. But on the other end of the spectrum, you don't want to dislocate their shoulder. So I tend to do that with them supine, their arm out over the edge of the bed, and having one hand at the front of the shoulder just ready to apply a little bit of posterior force if they're getting too apprehensive, and that generally stops the embarrassing event of dislocating the shoulder when they came to see you to have their shoulder dislocations fixed. It's nothing worse than ringing down to emergency and asking them to have some midazolam on and morphine ready for a shoulder reduction. So work up, leave those special tests for last. The posterior apprehension test I do on their side or supine, basically trying to drive with an axial compression their humerus posteriorly, and often they'll just experience pain. The anterior apprehension test, often they'll feel as though something bad is about to happen, this sense of apprehension. Posterior is not quite as specific as that, and they'll often just say that it's sore, and that's a positive finding a lot of the time for posterior labral or capsular pathology. And don't forget, someone mentioned it early, and I tend to do it at the end, but don't forget to have a look at their neurological status. And the number one nerve injured in instability or dislocations is the axillary nerve. And compare the sensation to the other side. Often the sensory loss will be very subtle. They won't have motor loss, but if you compare the sensation in their deltoid region, their military patch or regimental patch, you'll often pick up a sign. And especially if you're responsible in an emergency department for reducing one of these shoulders, you want to know their neurological status before you do anything to them, because they may blame you for giving them neurology after trying to put their shoulder back. or if they're about to have surgery, you want to know that their axillary nerve and their rest of their brachial plexus is working. It is uncommon to get a vascular injury, especially presenting to in the outpatient setting in a GP practice, but it's worthy to make sure their hands will perfuse and have a feel of their pulse for comprehensiveness, but unlikely to yield anything. And we'll talk about a little bit more about this in the case, but basically the differentiating between active, passive movements is really important in not so much instability, but coming up with a really accurate diagnosis. So I think it's worth spending a little bit of time seeing what they can do, and then you seeing whether you can improve that passively and whether there's a difference. So not just getting them to move and being happy with that, spending a little bit of time you doing the passive movement as well to see whether there's a difference. And that's really important in pathologies a little bit outside of Lachlan's case, but frozen shoulder and arthritis, often they're missed because patients will come in with an ultrasound leading you down a bursitis, impingement, rotator cuff path, but they'll often have associated pathologies that will be more important than that if you do a detailed exam.
Thanks, Dale. Okay, so we've taken a very good history from Lachlan. We feel like we have a bit of an idea what's going on, and we've had a chance now to examine him with that background knowledge. There's a good picture there. So Dale, did you want to comment on the left?
So just it's a good time to show this picture because this is a sulcus sign, and a sulcus sign can be in patients without history of shoulder pathology. So it's not necessarily a sign of pathology, but it certainly predisposes to instability type problems in joints, especially the shoulder. So this, as Sharon said, it's an inferior laxity in the shoulder when you apply a downward force. When the patient dislocates the shoulder, it's almost the ultimate sulcus. Their shoulder's sitting anterior and inferior, and you'll see a sharp drop in the lateral border of their deltoid from the acromion down. Some patients can actually do this with voluntary muscle movements who are really loose. The other thing about these patients is they don't often, not always do they tear anything. Their capsule, their elastin in their joints is so lax that they can sublux and even dislocate without tearing their labrum, which is the usual thing torn in a shoulder dislocation.
So as I was saying, we've done his history. We feel as though we've safely examined him. Now we have to come up with a plan for Lachlan's investigations. I'm happy to take any ideas for what we're going to write on our radiology form. How are we going to image his shoulder to give us the best answers? And there's no wrong answer here, I don't think. Plain x-ray, including both sides, so we want comparison views. Exactly, so that'll give us the bony anatomy, particularly of the glenohumeral joint, won't it? That's right. So plain x-ray. What else might we be considering at this stage? Ultrasound, exactly. Ultrasound to give us a better look at those soft tissue structures. And Prof Gibbon will take us through these modalities in a moment. Anyone with anything else? Okay. I'm going to now hand it over to Prof because I think he's going to talk us through, in his mind, what the appropriate uses of our various imaging modalities would be in this situation.
Thank you. The first part of any investigation for acute trauma actually should be a radiograph. The reason why I say that is that you have to exclude bony injury. You have to exclude any obvious joint subluxation or dislocation. It's quick, it's simple, it's cheap, and if you've got a bony or joint injury in that acute setting, it will actually usually give you the diagnosis. The question about doing the other side is very rarely required in truth. You can usually get the information just from the side that you're looking at, but that again depends on how familiar you are looking at the imaging.
I concur. I think the first line investigation for all pathologies who present to me, chronic and acute, and I can't think of an exception to this, is a plain film. For the reasons Prof Gibbon said, you've got to document at some stage that the joint is located and there's no fracture. Once you've established that, there's still yield in a plain film. And often the signs will be subtle, but if you know what you're looking for, sometimes that's the only radiographic modality you'll need to guide treatment. Often we'll go on to do more elaborate investigations, but plain film is the number one. Now, if Lachlan had an anterior dislocation, the types of things we're looking for, so in the instability settings, we've mentioned one, you want to look at the bony anatomy or the bony architecture of the glenoid and the humerus. And when you first look at an x-ray like this, you may be forgiven to thinking, oh, well, the shoulder's located, there's nothing obvious, and move on. But if you look closely, where the blue and the red arrow are, there's a disruption in the subchondral line of the anterior glenoid. And this person has actually got a glenoid fracture. And if you look at the lateral, you can see it. I haven't got the pointer here, but Sharon might be able to just show antero-inferior on the lateral. There's a separated piece of his glenoid. So this really makes the whole situation a little bit more urgent. And if this is missed, it can mean the difference between an internal fixation and a more complicated reconstruction procedure. The second thing is, even though this is an AP of the shoulder, it's not really even a true AP of the glenohumeral joint, there's a suspicion that there's something wrong on the superior aspect of the proximal humerus. And this is a subtle Hill-Sachs, and if we had a rotation view, it might even be more exaggerated. But even on a two-view series, an AP and a lateral of sorts, there is good yield in plain film. And I find this, especially in the dislocation, far more useful than ultrasound as your first-line investigation. I tend to order, and I'll be interested to see what Wayne says about this, because there's lots of different age groups presenting with lots of different pathologies, and you're formulating lots of different differentials. I tend to stick to 5 views as my sort of standard views for a shoulder. Whether it be a young patient and you're worried about instability, or a middle-aged to older patient, you're worried about cuff pathology or calcific tendonitis or frozen shoulder, or an older person who you're worried about osteoarthritis of the shoulder. I ask for a true AP of the shoulder joint. And that's different to an AP of the shoulder or the chest, because there's a version angle on the glenohumeral joint. So if you ask the radiographer for a true AP of the shoulder, they'll allow for that, and you'll get more information about the margin of your glenoid and humerus. I ask for an internal external rotation view, and in trauma that's useful for indentation or impaction fractures such as Hill-Sachs. In rotator cuff pathologies, it's useful for occult calcium deposits, so it may bring a posterior or an anterior calcium deposit into view that a normal AP would miss. I also ask for a lateral or an outlet view, which is a variation on a lateral. There's a subtle difference, but a lateral of some sort. And I also ask for an axillary view. An axillary view can save you sometimes, because an AP you can sometimes miss, and I haven't got a x-ray of this, and I'm sorry I haven't, but once you've seen it, you tend to remember it. But a posterior dislocation, if you're busy and you have a cursory look at the x-ray, may look reasonably normal. It's not like an anterior dislocation that's out and there's a huge gap under the acromion. This is a lot more subtle than that. And even the lateral, especially if it's been left a while, what happens is the humerus buries into the glenoid neck and you get a reverse Hill-Sachs, and it'll actually look reasonably located. And sometimes the changes are very subtle, but on an axillary view, you'll see the humeral head hopefully sitting square against the glenoid, the socket, and you can be confident that you haven't missed any subtle dislocations. And picking up a posterior dislocation early is a really advantageous thing for the patient, because it might mean just a simple reduction fixes them. If the average time of picking one of these up is 6 months, so if it gets to 6 months, it's no longer a simple reduction. It's usually some sort of complicated reconstructive procedure, sometimes even a joint replacement in a young patient, which is something we try and avoid. So plain film is still the key for the first-line investigation.
The only comment I'd make about the axillary is sometimes if it's actually very painful for the patient, like you can't actually get one done, and that's why the lateral scapula, which was the second of the images up there, can be useful in that respect. In terms of radiation to the patient, and sometimes we worry about over-irradiating, and you can understand that. But I actually remember a colleague of mine saying one truism. If you show me one patient that died because they received medical radiation, I'll show you 10 that died because they didn't receive medical radiation. When you're actually talking about doing individual studies, the important thing is to actually get the diagnosis. Most of the radiation burden information actually goes back to data from Hiroshima and other things. Okay, so it's a population data. But in terms of an individual, your risks of not imaging are actually much greater than your risks of imaging. The issue about posterior dislocations on a frontal radiograph is that if you've got a true AP of the glenoid, so the glenoid looks a nice square structure, the humeral head should always be congruent with it, okay, because they're articulating with each other. If you've got a posterior dislocation, then rather than being congruent, one tends to overlap the other. And that's the other clue about a posterior dislocation on a frontal radiograph. In terms of ultrasound for acute trauma, the reality is that there are very few instances where ultrasound is useful in an acute trauma episode. There are lots of pathologies that ultrasound is very good at, but in terms of an acute injury, it's not going to give you much more information. The few exceptions of that are, say, if you're a rugby league player, they've actually gone like that trying to tackle someone. You're worried whether they've got an acute tear to the pec muscles. That is a reasonable time to be doing ultrasound. In the vast majority of instances where you've got an acute severe trauma episode, and particularly in this young group, and Dale is actually right in saying about the age being relevant. In the young age group, you're actually looking about bone injury and joint subluxation. You're not usually looking at tendon pathology. In an elderly patient that's got a weakened tendon, they can pull them apart. In a young individual, what usually happens is the weakest link in the chain is not the tendon, it's the bone, so it pulls the bone off. So in terms of a rational approach to what you're going to do with someone with an acute injury to the shoulder that's acutely painful, the plain film is overwhelmingly the first thing to do, and it's only if you haven't got anything on that that you really start thinking about other imaging modalities.
Talk us through now, as I said, some of the different benefits, the advantages and the disadvantages of the different modalities, and really what our full list of options are and what we can gain important information from.
Okay. This is an example of another Hill-Sachs lesion, okay? It's an impaction fracture, and that's all that you're talking about. The inside of the bone is like a violet crumble crunchy bar, and you can squash it down. And if you squash it down and impact it down, that's what it ends up looking like. And you can see that the joint is actually in place at the moment, okay? Because if that's the bony glenoid, that's the humeral head, they actually look like they're congruent with each other. So the inference from it is that they've had an anterior dislocation with a Hill-Sachs lesion, but at the present time that it's in place. If you're worried about whether they had an AC joint injury, a lot of people then say, well, should we be doing weight-bearing films? The reality is, as long as the patient actually is not supporting their arm, then the AC joint will actually drop down under gravity and under the weight of the limb. So there isn't much need for adding to the pain of the patient, particularly in the acute circumstances, by getting them to hold any weight or otherwise. And the clue then becomes the planar aspect. If you look at the inferior aspects of the acromion relative to the inferior aspect of the clavicle, they should be in line. If they're not in line, then you start wondering about whether they've got a subluxation at the AC joint. Now, these are a little bit more dramatic. So you've got a situation here whereby you've actually got anterior dislocations. And you can see that this is the lateral radiograph of the scapula. So you've got the coracoid process in the front, you've got the acromial process at the back, you've got the scapula coming down, and it forms a Y shape. And the middle of the Y should have the humeral head. In this instance, it's not sitting there, it's sitting there because it's out anteriorly. And you can see it's come out here anteriorly and is sitting beneath the coracoid process. And as discussed, they then get an impaction fracture that can be subtle when it gets put back into place, but that's why it's occurred, is because the back of the humeral head is impacted against the inferior aspect of the bony glenoid, and obviously if it goes out the other way, it's a reversed Hill-Sachs lesion that you get. You can also get a bony Bankart lesion, which is where you've actually got a rim of bone taken off because the labrum has got a bony anchor. And you can rip the labrum off on its own, or you can rip the labrum and a little bit of the bone off. And so when you actually see a little rim of bone there, that's the so-called bony Bankart lesion. And that really is essentially pathognomonic of the fact that someone's had a dislocation of the shoulder. Does anyone know what luxator erecti is? That's the third form of shoulder dislocation. It occurs in less than 1%, and that's where you get an inferior dislocation. And you'd know it if you ever saw a patient, because they come into casualty like that, because the shoulder dislocates underneath. And I actually once saw when I was a casualty officer in Oxford, the patient had actually been working under a car, and the car had suddenly collapsed, and they came in with bilateral ones. It was very difficult not to laugh. In terms of if you want confirmation in terms of what's happening to the labrum, really the only modality that's going to give you the clue is to do MRI. It's not strictly true, as I'll show you, but to all intents and purposes it is. Here you've got, this is bone bruising, it's trabecular bone injury, and that's the Hill-Sachs lesion that you're actually seeing in terms of the compression fracture. Here you've actually got a little triangle at the front, which is the soft tissue labrum, and the little gap in between the two is where the soft tissue labrum's been pulled off. I suspect there's a little fracture going through there as well, so that's got a bony as well as soft tissue Bankart lesion. It's at the front there because the humeral head's gone out at the front. As I'll show you, you can actually get the reversed aspect of that, where it goes out through the back. But MRI is the best way of trying to demonstrate labral injuries. In the acute setting, the body generates enough contrast medium of its own, i.e. the hemarthrosis, the joint effusion. In a chronic setting, then you've often got to give yourself a bit better chance, and you put dilute gadolinium DTPA into the joint, so you actually do it as an MR arthrogram. But MRI, either as an arthrogram or not, is the best way of imaging in terms of labral pathology. And you can do it in two directions. If someone has got joint hypermobility, there's a tendency to be able to shift the shoulder joint out to the front, but also to shift it out through the back as well. And because of that, not only might you get the soft tissue Bankart lesion at the front, but you may get one at the back as well, where you've actually had both an anterior and posterior subluxation or dislocation of the joint. And it can actually go all the way up circumferentially around the labrum and virtually avulse the whole lot off. Just one last thing. As you may be aware, as I'm sure you are aware, that for GPs referring for MRI of the shoulder is slightly problematic. It shouldn't be forgotten that CT arthrography is what we used to use before MRI and MRI arthrography. And in patients that can't have an MRI because of claustrophobia or they've got a pacing wire in place, it actually is still a very useful tool, because if you do it properly, you can see the labral pathology just as well. So that's now the contrast, negative contrast of air, positive contrast of the water-soluble contrast. And you can actually see that's the soft tissue labrum being outlined. There's the little bony Bankart lesion. So you can get information of CT arthrography as well, particularly in patients that can't undergo MR arthrography, and occasionally, because for other reasons, they can't undergo MRI.
So for the purposes of discussion, we're going to say Lachlan has had a first-time anterior dislocation without any complicating factors such as a large fracture of his proximal humerus or a large fracture of his glenoid. So the most likely pathology in a first-time young male traumatic dislocation is a soft tissue Bankart lesion, which is an antero-inferior labral tear. Now, once you've had that or had that dislocation that results in that, especially in a young patient, especially someone less than 20, you have a reasonably high chance of having a further dislocation in your life. But there's factors to be taken into account. With the patient, if Lachlan was wanting to return to at-risk activity like skiing, contact football, surfing, swimming, things that involve abduction, external rotation, then I would be considering him for, once he had rehabilitated his shoulder, so he had a reasonably supple range of motion and comfortable, for a stabilisation procedure. But for most patients, especially if they're older than 20, they're not elite sportsmen or just wanting to do non-contact, less risk activities, then I would be maximising his non-surgical management with physiotherapy. So I do put these patients in a short period of immobilisation in a shoulder sling. We used to say to put them in a sling for 6 weeks. I think that's probably too long, so put them in a sling for comfort, and until their pain settles down and they're comfortable moving their shoulder, get them to see a physiotherapist, and I ask them to work on regaining their range of motion and progressing their muscle strength, working on their rotator cuff stabilisers to try and make Lachlan aware of the at-risk positions of his shoulder. If he was to fail the non-surgical management, then I would consider him for a surgical procedure. And failure doesn't necessarily mean all the way to a second dislocation. If he's apprehensive in certain positions in an ongoing way after he's regained his muscle strength and his range of motion, then I would consider him for a stabilisation. But most patients who are not competing in at-risk activities will do well after a first-time dislocation and not go on to need surgical intervention. But after recurrent instability, I think that's second and third dislocations and consequential dislocations. There's too much trauma to the joint, and the risk of long-term problems in the joint, such as post-instability arthritis, become too high. I would offer that style of patient a stabilisation procedure. The problem with leaving patients to recurrently dislocate is they end up getting secondary changes in their glenoid, and sometimes you go from having a successful soft tissue procedure as the reconstruction to sometimes having to do more elaborate operations such as bone transfers. The other thing about getting these patients early, so you're not seeing them after 10 dislocations. Once you've had 10 dislocations, not only is the labrum torn, but often you get secondary capsular stretch, and the results of surgery are not as good as if the capsule's not stretched. So generally, as a rule of thumb, first-time dislocation in most instances is non-surgical management, but occasionally in the very young patient, the very high-demand patient, patient who going to an at-risk activity after their dislocation, then we'll consider surgical intervention. If they are a high-level athlete, a footballer, if they have a first-time dislocation in season and they haven't got a secondary problem like a fracture of the glenoid or significant hill sacks, then often we'll defer their surgical intervention till the end of the season, try and rehab them in season, and sometimes it'll involve taping or strapping of their shoulder to get them to that. But if that's unsuccessful and they have a second instability episode, then we will pull them out of that season and do a stabilisation procedure. This is a CT scan of a patient of mine. He's sort of not professional. He has played for the Lions Australian rules team, but has now been demoted to a local team. And he had a recurrent dislocations on his other shoulder, the shoulder that I'm not showing the CT of, and I've done a stabilisation procedure, got back to football and dislocated his other. But this shows a little bit of the pathologies we're talking about, in that this is a axial, if I can get this, axial CT. So humeral head, this is quite low in the glenoid, and the glenoid's starting to get narrow here, but he has a bony Bankart. And on his other side, he also had a bony Bankart, which was a little bit bigger than this, and we did a bone block stabilising procedure, which is a bit of a variation on just a simple labral or Bankart repair. This is his hill sacks posteriorly, and I would call that a sort of moderate size hill sacks. And this is a 3D reconstruction with subtraction of his proximal humerus, so we can see the glenoid face on. And the shape of the glenoid in the normal anatomy is a little bit like a pear. So at the inferior width of the glenoid should be wider than the superior width. And this is not an inverted pear. If it gets to the inverted pear stage, then soft tissue procedures tend to fail, and we tend to do bone procedures. But because he has this fracture and he'd had a successful outcome with a bony procedure on the other side, I went ahead and did the same thing on this. And basically this is called a Radiology procedure, named after the Frenchman who described it, which is a coracoid transfer down to the antero-inferior part of the glenoid. And this is a side-on shot, so we're increasing the width of the glenoid. It's not an actual physical block at the front of the shoulder stopping the humerus popping out. It's increasing the width of the glenoid to make it harder for the hill sacks to shift over the antero-inferior margin of the glenoid and dislocate.